Thank you so much, and thank you, Anne, for having us, and Cole and David for representing Migrant Health. So I'm going to be talking a little bit about innovative ways to link existing data sources, with a focus here on migrant health in the UK. So I'm going to start talking about a few different methods of data linkage, with a focus on probabilistic data linkage. Then I'll go into a case study which examined tuberculosis in migrants moving from high incidence countries into the UK. And lastly, the implications of these methods on our current research. So there are a few different main types of data linkage. Exact matching, which is almost kind of what you would think in the name. If you have two data sets, and they can be matched by some universal unique identifier. For example, in the UK context, NHS number, or in the US, where I'm from, Social Security number. And that, for all data scientists and researchers, would be amazing if all data had this unique number that we could just link together. But as we know, often those kind of unique universal numbers are not available. So two other methods come to hand. Deterministic matching is matching two data sets by a set of rules of agreement. For example, if you have two data sets, you might link them by address, such as postcode and house number, name, surname, and first name, or date of birth and sex. While probabilistic matching is a methodology that accounts for the chance that two records within two data sets have the same value for a variable, or the same values in a series of variables. And certain variables within this can suggest a stronger match. For example, within two data sets, the fact that one person, potentially, that could be a match, is a male or female, compared to having the same surname. So a surname would be kind of an indicator of a stronger match, and would have a higher weight generation associated with it. And I'll get to more details about that method in a moment. So that is the method that we've used in our research to be able to link two different data sets to better kind of understand migrant health here in the UK. So probabilistic data linkage. We've used a system that's built by colleagues at Public Health England called Enhanced Matching Systems. And this was developed using a Transect SQL and Microsoft SQL server database. And it's based upon methods described by Newcomb. And what's so exciting about it is that it's highly configurable for many different projects. So not just migrant health, but can be used from all of the different disciplines I think you all come from. So steps involved in carrying out an EMS matching project, kind of starting with any data science, cleaning of the data. But what we start with is those variables that we're going to decide to link our data sets. So something such as kind of making sure that our addresses are separate by house compared to postcode, and that the punctuation is the same between different names. And then we do something called blocking. And because we're looking at probabilities, so if between the two data sets, let's say we've agreed upon or looking at a series of variables, and we're looking at all the combinations of those variables, and that would just be a huge process to do all of those probabilities and calculate the sum of that. So we focus on a few blocks. So we focused within this study with just the surname, soundex, year of birth, and postcode. So we do our weight generation of that, and that has to do, again, without getting into all of the math, about the fact that more unique or more rare variables, such as a name, compared to someone's sex, will have a higher weight associated with it. And these weights then can be added up, and the cumulative of a weight will be, if it's above a certain threshold, then that is indicative of a true match. If it's below a threshold, then potentially not really a match. And we've had, for the processes that we've done, actually someone who goes through and looks at a certain proportion of those matches that are right around that threshold to determine, is it above that threshold? Is it really a true match or no? So how good is this linkage system? So we conducted a review and a sensitivity analysis looking at probabilistic linkage. So we took TB case notification data here in the UK and linked it to laboratory confirmation data of positive TB outcomes. So by linking the two, we used NHS numbers between the two data sets as our kind of example of exact matching. So we excluded everyone who didn't have an NHS number and just linked upon that. And then we excluded the NHS number and did probabilistic linkages based on surname soundex. And soundex is an algorithm that uses both letters and numbers to account for miscoding or misspelling in names, as well as year of birth and postcode. And that can even just be the first two, either number or letter of the postcode. And we found with that we had a sensitivity of 99.5 and a specificity of 100%. So it was so exciting about this new validated methodology that it's allowed us to kind of continue our research since then with me and my team at UCL. So a case study of this is we examined tuberculosis incidence and risk factors associated with tuberculosis in about 500,000 migrants in the UK. So with the help of the IOM, the UK has set up a pilot pre-entry screening program for active tuberculosis. So starting in 2006, going to 2012, this program was brought out to around 11 different countries of high incidence TB. And visa applicants who were above the age of 11, who were coming to the UK for more than 6 months, had to get a TB chest scan. So they started with getting a chest scan. If there's no signs of TB, medical clearance, get your visa, get on the plane and come to the UK. However, if TB was suspected in that chest radiograph, then there was a sputum test. If there was no TB, if that was a negative test, they ended up getting medical clearance, come to the UK. Great. However, if you did have TB, you did not get clearance, and then hopefully go through the 6 months of treatment, and then you could reapply. So these two squares here is where we create our cohort. So all of the migrants between that period that came to the UK on a visa that were medically cleared, had no tuberculosis at the time of the test, we probabilistically matched them to TB cases, case notification data here in the UK. And so we excluded duplicates, those that migrated to Scotland, because the TB case notification data is only for Wales, Northern Ireland, and England, as well as missed prevalence cases, so people who got TB within those first 6 months. And so with the natural history of TB, you can have latent TB, which then can reactivate and become active TB. So it's possible to miss those cases. So we included in total about 500,000 migrants. So some of our findings, which was quite exciting about kind of almost creating this longitudinal cohort, is these migrants who came into the UK without TB, we were able to identify certain risk factors. So if they had kind of a more traditional risk factor with TB is having contact with someone with TB, and that was also seen in our work, as well as if you had a pre-entry X-ray result that was then a bit suspected of TB, but then you got the sputum test and were negative, those individuals had about 3 times higher the risk of then eventually developing tuberculosis. So we had an incidence rate of 147 147 person years per 100,000 person years. And so as you can see here, a majority of migrants do not develop TB. And what's so important about this is often, as something Cole and other people have touched on, is the narrative about migrants and the health of migrants can also often be that migrants come into countries and bring infectious diseases. But actually, they really pose a negligible risk of onward transmission to the host population. And where we need to be kind of shifting resources is actually to support migrants themselves. So this was an evidence base that we could help improve our pre-entry screenings. For example, the people that had some type of pre-entry X-ray result that initially showed some type of TB, but then were negative through the sputum test, could we do some type of mop-up campaign of latent TB here in the UK? So these type of results has led us to our now new 5-year project, which we are called the Million Migrant Project. So we're using this cohort, which is now over 1 million migrants, because in 2012 we expanded now to 101 countries where these pre-entry TB tests are happening. So of those migrants that came to the UK, we're going to be probabilistically linking them to primary care data as well as hospital data. Because currently in the UK, we really have no idea what migrants are getting sick from. Because when a migrant goes to the hospital or to their A&E, ethnicity might be recorded, but not where someone's from. So we don't know what's the percentage of migrants having diabetes in the UK. And so without having those numbers or that data, we're not able to allocate resources and kind of shift policies to affect that. So we're starting this process as well, and we're going to be looking at death registrations to better understand mortality. Our second project is using big data and mobile phone apps. So where we're going to be recruiting migrants. So migrants go through a pre-entry TB test a month before arrival. We're going to ask them through email to see if they'd like to download an app, a mobile phone app, and participate in a data collection process for 1 year. And we're really looking at the larger social determinants of health. So not just how they're feeling today, but how do you feel living in the UK? How does your housing feel? Kind of what type of exercise are you doing? How is it, how have you been treated by people here? And so hopefully after this 1 year study, this is almost like a health needs assessment, we're kind of thinking of it as. After that, hopefully we can do some type of intervention based on what we find. And here it says the primary outcome is obesity, but actually we're kind of looking at it more as a needs assessment to then potentially see what the true needs are and adapt accordingly. So I'd like to thank my supervisor, Dr. Rob Aldridge, and my funders. And lastly, a quick note. It's really been such an honor to be here, to be able to talk about this. And something I think Cole and I and Dave were talking about is often we end up going to health conferences and talking about migration. I know this is my first time at a migration conference. And it's really great to get the different perspectives. And so we have started just in the last couple years, with also Chesmal as well, a new kind of network called the Migration Health and Development Research Initiative. And we're working together not just with academics, but people from civil society, NGOs, UNs, policymakers, and migrants themselves to come together to build the migrant health research agenda. And some of our main kind of our vision and mission is to help support research production and kind of those conversations within the Global South. So a lot of those points that Cole pointed to, that we really have a gap there, and how do we support researchers and practitioners in those areas, as well as supporting early career researchers. So if you have any interest, come chat with Cole and I about it. And what's really exciting about it is you don't have to be part of any type of university or institute. It's about individuals joining this network and working to improve the lives of migrants. Thank you very much.